So the next section looks at how we use science and politics in the US to build our overall immunization system. The first effort to get rid of measles in the US began in the mid-1960s. Vaccine was licensed in 1963, and people thought measles could be a candidate for eradication. One, it was a virtually universal infection, and it required humans for transmission. There were no non-human reservoirs. And so if you broke the chains of human-to-human transmission, you could get rid of measles. Chronic carriers and shedders did not exist. This is before they had discovered subacute sclerosing panencephalitis, which is a chronic infection, but the virus in subacute sclerosing panencephalitis is not contagious, so it is correct. And transmission is dependent on the balance of immunes and susceptibles, and you can, if you achieve herd immunity, terminate transmission. Obviously, they totally miscalculated herd immunity. They estimated the herd immunity threshold was 55% at the time, which said, hey, this is doable. They were completely wrong. It needed much more. But in a sense, poor science turned out to be good for our efforts both to finally get rid of measles as well as to build our system. And there were 4 components to it: routine immunization, immunization on school entry, because what we found because of surveillance, which was another critical component, is that a lot of our kids were getting their disease in schools where contact rates are higher than they are in preschool populations. We needed higher immunity levels in school populations than in infant populations or young child populations, and then doing outbreak control. And what led to that? One is we had established in 1962 a federal assistance program to our states for immunization. And measles was the first new vaccine license. So there was say, hey, we can now use these funds to build on measles and to build a more vigorous domestic immunization program. The initial considerations for measles elimination or eradication in the US had nothing to do with worldwide eradication. It was basically, let's just get rid of it in the US. And what was the impact? There was a substantial impact. There was a greater than 90% reduction in measles cases from the over 500,000 to about 22,000 in 1968. And the 500,000 is a substantial underestimate. Our birth cohort was about 4 million in that period. Since everybody got measles, the actual number of cases was about 4 million. And even with better reporting as a result of the enhanced surveillance, we had more than a 90% reduction. And here, the first mistake got made, or one of the first mistakes. And that is, hey, we're great, things are great. They switched funding completely to rubella. They said, let's declare victory, even though we weren't at 0. And what they didn't realize is what I said earlier, is each day, even at these low levels, new susceptibles are born that can fuel large outbreaks in the future. And this just shows you an example. What happened is in 1965, we were at over 250,000 cases reported. By 1968, we were at 22,000 cases, and then we switched, and lo and behold, we had another major epidemic. And this led to a lot of efforts to try and avoid that. Cases came down, and then again, things weren't done, and we had to have another epidemic. You would have think we would have learned our lessons, but we didn't. We kept saying, oh, this is great, these low periods, we don't have to worry. And what was also being learned in this period is that smallpox was being eradicated with an outbreak control strategy. Detect cases, isolate them so they don't transmit further, identify contacts of potential contacts, vaccinate them, and block it. And the question was, could we do that with a similar strategy? And then people began thinking, hey, if we can get rid of measles in the US, perhaps we could take on a worldwide effort. The other thing that we were learning is the importance of school laws, the school record check. And what we found is that states with school laws, and in the US, we were fortunate that we didn't have to have a national law. We had state laws, that states who had laws had lower incidence rates of measles, and hence illustrated to other states, you ought to get a law so you can reduce your measles. The other thing we found is the epidemiology changed, and that's why surveillance is so important. And what we found is kids who would have gotten measles at an earlier age were not exposed with the impact of vaccination. They survived to older ages, still susceptible. And we had outbreaks in our middle and high schools, which are basically teenagers, because they have higher contact rates in those populations, and those immunity levels were insufficient. And the other thing we learned is the importance of political leadership. Now, what we didn't recognize is how different the diseases smallpox and measles were. Smallpox, I could teach a layperson how to make that diagnosis when I worked on smallpox in India. It was that distinctive. While measles is distinctive in terms of having rash, illness, of fever, there is a differential diagnosis, and you need laboratory tests to confirm it. Number two is the R0 values for smallpox were a lot lower than measles. We needed much higher immunity levels, and you could see here the differences in smallpox and measles. With smallpox, the spread before rash was very rare, whereas with measles, the spread started with the prodrome, which predated the rash by 2 to 4 days. And often at that time, the kids or the individuals were not that sick, and the spread was very common. And so it was very difficult to identify who had been exposed. We had a very effective one-dose intervention with smallpox. With measles, a good one dose, about 85% effectiveness at 9 months, over 90% at 12 months, but not as successful, particularly when you had to reach these immunity levels. And with smallpox, you could look and see who was protected by whether they had a scar. With measles, there was no way. You had to take a blood test, so you couldn't tell who was a vaccine success and who was a vaccine failure. And this is an example of how contagious measles could be. This is an outbreak investigation I did. It was one of my first outbreak investigations when I was at CDC, and looking at the introduction of measles into Defiance County, which was a rural county in the state of Ohio, and looking how it spread through church contacts, through contacts in libraries, through music lessons, through sharing common facilities, being on school buses together, play fields, preschool neighbors, transfer students, etc. Measles was far more contagious. So we should have known that an outbreak control strategy was probably not the best way to take on measles, but we didn't. And then what happened is an outbreak of measles in Los Angeles County. In mid-January of 1977, the outbreak was detected. Despite efforts to control it with school-based vaccination, By mid-March, there were 2 deaths, 3 encephalitis cases, multiple pneumonia cases. And the health officer in Los Angeles County, Shirley Fannin, got so frustrated that she said, if you do not get vaccinated by May 2nd, she was going to throw you out of school. And what they did is they held clinics in schools, night and weekends. And lo and behold, by May, about 50,000 kids of the 1.4 million students were still without evidence of vaccination and were thrown out of school. Many of them were vaccinated, they just didn't have their records. But this set the precedent. If you could do it in Los Angeles, you could do it anywhere. And this is how we controlled outbreaks. And pretty soon it became clear that we shouldn't be in the business of controlling measles outbreaks. We should be in the business of preventing measles outbreaks. And this led to our no shots, no school policy. And so, in essence, a scientifically flawed strategy led to programmatic frustration and led to our building of a system that not only had impact on measles, but all of our vaccine preventable diseases. And this just shows you some of the measles data in 6 states that were strictly enforcing school laws versus other states. And before they did it, they had similar measles incidents, and within 2 years, they had a greater than 90% reduction. And this was helpful in selling to other states, hey, you ought to get behind development of enacting and enforcing such a school law. And the other thing that we noticed is that the epidemiology was changing. In the 1970s, most of our cases were in the school-age population, hence the focus on schools. But as time went on, our next outbreak, the most common age group affected, was our preschool children, 0 to 4, and we needed to do something about them. And that's when political leadership became so important. And our heroine, who just recently died, was Betty Bumpers. She was the governor's spouse in the state of Arkansas, married to Dale Bumpers, who was governor at the time, and she became interested in immunization. And she then convinced Rosalind Carter, who was then the first lady of Georgia, of the importance of immunization. And Rosalind Carter's husband became president in 1977. He was elected in 1976. And we got a presidential initiative on immunization. And it was amazing. The first initiative was to get 90% immunization, to establish a permanent system of immunization, and the focus was an enactment and enforcement of comprehensive school laws covering not just measles, but all of the recommended vaccines. The other thing we learned is we need a constant level of funding. This just shows you in 1965, where we had measles cases, we had a big upsurge of dollars, measles down, dollars down. Dollars down, measles up. Measles up, dollars down. Measles down, dollars down. Measles up, dollars up. Dollars up, measles down. Measles down, measles down, dollars down. Dollars down, measles up. And so the need to illustrate, we need to continue to maintain our efforts. Again, because we have new susceptibles entering the pool every day. In 1978, we had a measles eradication strategy to focus in the US to eliminate measles by 1982, with again, high coverage with a single dose, surveillance, and a prompt response to outbreaks. And we had some success. Measles incidence dropped from 57,000 cases in 1977 at the time of the presidential initiative to about 3,000 cases annually in the 1980s, less than 1% of the total prior to vaccination. And we saw a pattern of two types of outbreaks. And one of the concerns was one dose adequate? And this is where epidemiology became very important. We classified our outbreaks in those where preschool children predominated and where school-age children predominated, and they had very different patterns. For preschool problems, we had very few of the kids vaccinated. And so the problem with preschool outbreaks was to get that first dose into children. For school-age outbreaks, it was quite different. The big problem was vaccine failure. And here, the concern was one dose adequate to do the job? And there was a lot of debate. If one dose in the United States was about 90% effective, then the two doses, or the second dose, only contribute about 4 or 5% effectiveness. But the question was it worth it? And we had not achieved the high coverage with one dose that we desired. Should we just focus on getting that one dose in? And this just shows you an example of the epidemiology prior to the resurgence we had in 1989. And you could see here, failure to vaccinate, the white bars, was a big problem in the preschool kids. Vaccine failure was the big problem in the school-age kids. So what happened is we had a meeting, and here's again where politics prevailed. We had a meeting in New York State, and we had problems with outbreaks in our colleges with one dose failure. And the one dose failure does not appear to be waning immunity. It was a large number of college outbreaks. It was failure to respond to the first dose. And revaccination in outbreaks, which was a policy that was recommended for these one doses, was frustrating and difficult. Most of the academic experts bought into a two-dose strategy. The public health people said, that's awfully expensive. Let's do more on the one-dosers. And what happened is the health officer from New York State said, don't worry about cost. Tell me what the right thing to do is. And the experts said, give people 2 doses. And I remember I was at that meeting coming back to CDC, and my boss at the time, the acting director of CDC, said, we can't let them get out ahead of us in New York State. So we went for a national recommendation for 2 doses. So here is an anecdote, New York State leading to a 2-dose schedule. But the problem was that the American Academy of Pediatrics recommended the second dose at 11 to 12 years of age because that would have much faster impact on the vaccine failures were in our teenage population. Our public sector vaccine advisory committee, the Advisory Committee on Immunization Practices, recommended the second dose at school entry 4 to 6 years. And the reason for that is we already had an infrastructure at that age group because we had school entry requirements and because we had other vaccines recommended at that age, such as a DTP vaccine. What that happened is it drove people crazy. And it led to us developing a harmonized schedule where all of the private sector groups came together with the public sector groups and recommended a single strategy. And what you can see here is another factor that came out was the need for immunization measurement. This was what we did to measure coverage, and then because of budget cuts, we eliminated it. And we got a presidential initiative in 1993, and we reinstituted measurement, and we had high coverage at school and high coverage at preschool. So how did we get this second immunization initiative? And again, it was focused on politics, bringing in people from outside government who had some power inside government. And there was a group called the Children's Defense Fund, and they were an advocacy group for poor children. And they were looking for ways to measure access to care of poor children. And what is the one medical intervention recommended for all children repeatedly? Immunization, injections. And they figured out that the US Immunization Survey, which I showed you in the prior slide, showing low coverage, suggested poor access of care of children, and that we needed them to come and talk with government. And my initial feelings, I was director of the US Immunization Program, was to blow them out of the water because we felt our US Immunization Survey was inaccurate. And the best advice I ever got in my career was from my chief administrator, who said, if there's one thing you don't do, you don't tick off the Children's Defense Fund. And we invited them to our national conference. We became instant allies, and we then had an advocate in the Congress with the immunization system. And little did I know that Hillary Clinton was on the board of the Children's Defense Fund. And when she became First Lady of the United States, we got another presidential initiative. What helped spark that is a big resurgence of measles between 1989 and 91, where we had over 55,000 cases compared to an annual average of 3,000 cases, 123 deaths, over 11,000 hospitalizations, and the two groups of individuals involved, the unvaccinated preschoolers and the one-dose college students. And this just showed you the data showing the age at onset, and the big problem with the resurgence was failure to vaccinate. And this was these bars here, young kids who were not vaccinated.